This is the Psychcast by MD Edge, where we bring you interviews with leaders in the fields of psychiatry and psychology, masterclass lectures, and relevant inspiration with new episodes dropping on Wednesdays. I'm the voice of MD Edge Podcasts, Nick Andrews. And welcome to episode 104 of the Psychcast by MD Edge. Coming up on this masterclass edition of the show, Dr. Patricia Westmoreland discusses eating disorders. Dr. Westmoreland is an attending psychiatrist at Eating Recovery Center in Denver, Colorado. She's also an adjunct professor in the Department of Psychiatry at the University of Colorado at Denver, Aurora. And she has a private practice in the greater Denver area. Dr. Westmoreland has previously appeared on the Psychcast to discuss eating disorders. You can find a link to that episode in the show notes. Remember, you can find detailed information about this masterclass lecture in the show notes as well, courtesy of Dr. Jacqueline Posada. The notes include takeaway points on the topics covered, a summary of the lecture, and references that include links to the publications. And of course, we'd love to hear from you. We read emails and reviews. We take them seriously whenever it's time to improve the show. You can email the show at podcasts@mdh.com, or you can leave us a rating or a review on the Apple Podcasts app. Okay, without any further delay, please welcome back to the Psychcast, Dr. Patricia Westmoreland.
I'm Patricia Westmoreland, a forensic psychiatrist and attending psychiatrist at Eating Recovery Center in Denver. And I'm also an adjunct assistant professor at the University of Colorado Department of Psychiatry. Today I'm going to talk about the medical complications of eating disorders, specifically bulimia nervosa. It's been said that nearly all the medical complications of anorexia and bulimia can resolve with consistent nutrition and full weight restoration, regardless of how extensive they are. This is particularly true for individuals with bulimia who are generally close to normal weight, and in terms of their behaviors, if they're able to stop their behaviors before too much damage has been done, they can typically return to normal health. The way we think about eating disorders and medical complications, individuals who have anorexia nervosa, their medical complications are usually due to weight loss and malnutrition. What we're going to talk about today is individuals with bulimia nervosa whose medical complications are typically due to the mode and the frequency of their purging. Two types of purging in individuals with bulimia nervosa are noted. Firstly, self-induced vomiting, and secondly, laxative abuse. We're not going to talk today about excessive exercise, which some also consider a form of purging. So let's begin by talking a little bit about mortality in bulimia nervosa before we talk about morbidity. There's a lower mortality rate in individuals with bulimia nervosa as opposed to those with anorexia nervosa. However, people with bulimia nervosa have a mortality rate that's twice that of age-matched individuals because they can have severe electrolyte and acid-base disturbances that result from their purging behaviors. As I often tell individuals with bulimia nervosa, it doesn't matter necessarily what your weight is. You can be normal weight, you can be underweight, you can be overweight, but acid-base disturbances and severe electrolyte abnormalities can kill you at any time, without warning, and at any weight. 90% of those who engage in purging purge via self-induced vomiting or laxative use. In terms of self-induced vomiting, I'm going to begin by discussing a short little clinical vignette, and I will give you the answer to the vignette at the end of the section. This is a 42-year-old female with a 10-year history of bulimia nervosa. She was admitted to a residential treatment unit to interrupt her daily binge purge behaviors. Her current body mass index is 22, so she's approximately 100% of normal body weight. She stopped purging 3 days ago, but then her face became swollen and painful. Which statement do you think is true? A, she has edema. B, the diagnosis is sialadenosis. C, she should not be given anything sour tasting. D, you should give her diuretics. Or E, none of the above. So in discussing self-induced vomiting, there are local complications and, as I said previously, electrolyte and acid-base abnormalities. Local complications are those such as gastric reflux, which leads to dysphagia and dyspepsia, hematemesis, which is due to tears called Mallory-Weiss tears in the esophagus. There's epistaxis, which is nose bleeding, and subconjunctival hemorrhage. Oral mucositis, cheilitis, and peritmolysis can also occur, as can parotid gland enlargement and sialadenosis. In terms of electrolyte and acid-base abnormalities, an individual with bulimia can develop metabolic alkalosis, hypokalemia, or volume depletion leading to aldosterone secretion to maintain blood pressure, which is then called pseudo-Barda syndrome. I'll discuss that in a little more detail in a few more slides. In terms of treating local complications, acid reflux can be treated with proton pump inhibitors, and these individuals should probably also be screened for Barrett's esophagus, so that would involve gastroscopy or esophagoscopy. In terms of dental and oral issues, they should take fluoride mouthwashes. They should brush their teeth gently because their enamel may have been eroded, and they should practice good oral hygiene. In terms of parotid gland enlargement or sialadenosis, this should be treated with silagogues, for example, sour candies, and anti-inflammatory medications and hot packs. What about the treatment of electrolyte and acid-base abnormalities? Potassium should be replaced as needed, and if it's severely low, these individuals may need cardiac monitoring or a short stay in the intensive care unit. I have in my career seen individuals with potassium as low as 2, and it's very important to get them ICU treatment or at least cardiac monitoring and intravenous replacement of potassium pretty quickly. In terms of pseudo-Barda syndrome, with the cessation of purging, aldosterone doesn't normalize for a few weeks, and this is why these individuals develop edema. So as you'll remember, in terms of aldosterone secretion, when people are dehydrated, the body secretes aldosterone so that one can maintain one's blood pressure. But this does not just switch off right away when the purging stops, and that's why it doesn't normalize for a few weeks, and that's why these individuals develop edema, because remember, aldosterone makes you retain water. How do we treat these individuals? We give them spironolactone at doses between 25 and 200 milligrams per day. Let's get back to our clinical vignette. Well, remember, we have this individual who stopped purging 3 days ago. Her face became swollen and painful. And yes, while she may have edema at some level, the diagnosis of the swollen and painful face is parotid gland enlargement, and she therefore has sialadenosis. And we should actually give her things that are sour tasting. These are called silagogues, and these actually help reduce the inflammation. Let's talk about our second mode of purging in individuals with bulimia, which is laxative abuse. I'm going to start with another clinical vignette. This is a 50-year-old female with a 20-year history of bulimia, seen in your outpatient psychiatric clinic or your outpatient office. She confesses to purging through the use of laxatives, taking 100 stimulant laxatives a day. What should you tell her to do? Gradually taper the laxatives, that would be A. B, stop them immediately. C, tell her she can't damage her colon with laxatives, so it's okay to keep using them. D, give her diuretics. Or E, none of the above. So there's something called cathartic colon syndrome that occurs in individuals with bulimia. And what happens is that stimulant laxatives stimulate peristalsis by direct effect on Auerbach's nerve plexus. Continued use of the stimulant laxatives leads to nerve damage. These nerves are basically being overstimulated and overused. So the colon is then converted into basically an inert tube that it's incapable of propagating fecal material, and this leads to severe constipation. And in very, very extreme cases, individuals who have bulimia may have to have a total colectomy. We don't know how much time or how many laxatives it takes to cause cathartic colon syndrome, but once it's been caused, it is irreversible, and as I said, these individuals may have to have a colectomy. So the treatment is that the patients must cease laxatives immediately, and those are laxatives containing senna, cascara, phenolphthalein, or bisacodyl. So getting back to our clinical vignette, we really can't tell this person to gradually taper the laxatives, because by that point she might actually be causing further damage, and we don't know where along the trajectory the damage will happen. We certainly shouldn't tell her that she can't damage her colon, because, as I've said, she absolutely can. Giving her diuretics is not going to do anything. So we should tell her to stop laxatives immediately. And by the way, individuals who have been using laxatives for a long period of time can be treated with osmotic laxatives like Miralax without causing any further damage. But given their propensity to abuse laxatives, these laxatives should be given to them by a physician who should be monitoring or asking how much they're using. Typically on a residential unit, we will give these laxatives twice a day. And as I've said, osmotic laxatives, not a problem. Stimulant laxatives, big problem. So in summary, we discussed with individuals with bulimia, their medical complications are due to the mode and the frequency of their purging. And most complications are reversible for individuals with all sorts of eating disorders with effective treatment and nutrition. And I'd like to point out specifically with bulimia, this means stopping the purging, whether it be laxative use or whether it be vomiting. Thank you.
And that concludes the 104th edition of the Psychcast by MD Edge. I'm the voice of MD Edge Podcast's Nick Andrews. Remember, you can find references, takeaway points, and a summary in the show notes, courtesy of Dr. Jacqueline Posada. You can find links to more information about Dr. Westmoreland in the notes as well. Okay, let's give credit where credit is due. The Psychcast is produced by the editor-in-chief of MD Edge Psychiatry, Dr. Lorenzo Norris. The Psychcast is also produced by editors Jeff Bauer and Gina Henderson. All MD Edge podcasts are produced by our editor-in-chief, Dr. Ivan Oransky. Executive editors Mary Ellen Schneider and Kathy Skarbeck, and multimedia editor Terry Rudd. Social media is produced by Kyla Clark. I am your audio engineer, audio editor, and the voice of MD Edge Podcasts, Nick Andrews.